Hi! So I'm here to share with you one of our improvement initiatives regarding the admission handoff. It is the intention of this presentation to provide an example of how we can improve our processes. So why did I look into the handoff process as an area of improvement? This is because improving effective communication is one of the international patient safety goals, and that handoff is truly a high-risk aspect when it comes to patient safety. The problem background. Prolonged admission waiting time in the ED lead to increased boarding time in the ED, which is a significant cause of crowding. This is associated with delayed care for longer length of stay for other ED patients and decreased patient satisfaction. Prolonged admission waiting time is also multifactorial. However, a duplication of tasks was identified in the admission process. Improving the handoff process by eliminating waste can expedite patient admission in the ED, thereby optimizing departmental resources to better care for more patients. Problem statement. Unnecessary admission waiting time in the ED results in decreased quality of patient care, less available beds for patients requiring emergency services, increased departmental costs, and decreased patient satisfaction. One factor contributing to prolonged admission waiting time is the delay caused by task duplication in the handoff process. Handoff process across the hospital greatly varies, and an automated process to generate data from admission decision to patient departure from ED has not been established. This project has two goals. First is to establish an automated data collection process, and second, within 3 months after implementation, this project of eliminating waste in the handoff process targets a 20% reduction in the admission waiting time. In April 2019, Medicare has published that our door-to-admission decision time takes 282 minutes and our decision admission time to departure time is 92 minutes. This shows that our waiting times are better than other hospitals within the state and across the nation. The good news is that we can even improve this key performance indicator by carefully examining our processes. One of the processes that we can further optimize is our admission handoff. This slide shows the patient flow in the ED. So basically, I have used the lean method in waste elimination. I have identified several wastes here, like here is waiting. There's a lot of waiting problem there. Waiting. This is overproduction or inventory, duplication of task, also waiting. And this project focused on this part of the admission process. So the admission, in this admission process, we will be highlighting more of it in the next slide. So here is the process of admission. So when the patient is decided to be admitted, a physician has to put an order for admission, like an admit order. If the admission order is complete, like it's specific, what level of care the patient needs, what specific instructions or orders the patient needs to be taken upstairs or to be taken to a higher level of care, the registration will find a room for this patient. Of course, the registration will be coordinating with the charge nurses upstairs or in the ICU. And when the room has been assigned, the ER nurse will print a handoff tool. The handoff tool is a piece of printed paper that comes off from the electronic medical records. So in this medical record of the patient, there's a tab there. It says patient handoff tool. And it's like a form that you need to complete. And this has to be handwritten. And after the ER nurse completes this has to be faxed for the floor nurses to see. The floor nurses receive this paper, and then we can start calling for a report. When the report has been called, we can notify our unit secretary so they can call transport, and transport comes to the ER to take this patient to the floor. and then this patient will be taken upstairs. So basically, this project is focused on this part. Why do we need to print a handoff tool when in fact they can browse it from the electronic medical records? Because if we need to stick on this process, there will be defects here. Like, what if the fax machine is not functioning correctly, or there will be a communication error, or the fax machine upstairs is not working properly, or if the nurse upstairs is not aware that the fax has already arrived. So we would like to cut off that process. So our baseline data shows that overall, this process takes 83.6 minutes. It takes 21.7 minutes for admission order to room assignment, and that giving report alone takes, and that giving report to patient departure from the ER takes 61.9 minutes. Calling report is a value-added process. Value-added means it's important and it should not be cut off. This is a waste. I just had explained the lean process of waste elimination earlier. Waste means this can be taken out of the process without eliminating the value of the process. So our value here is the communication. Effective communication is very important in the handoff process. But faxing is just an add-on or a duplicate or an extra process, extra step in this process. So what are the causes of this delayed handoff? Technical issues like faxing defects. I have discussed that earlier. Second is unavailability of ED nurse to give report. Sometimes when the floor nurses calls the ER nurse or either party is not available or not ready to receive report. Duplication of task, faxing and calling report, and there's a variation in handoff process. Like, some of them does not follow this process strictly. Like critical care do not call, they're okay with that. They can read the chart, they know what to look for, they know where to check what. So there's a variation. And lack of automated data collection. Of course, we can't improve something that we cannot measure. That's why we recommend this process to have an automated data collection. Metrics and definition. Critical to quality metric. It is the number of minutes from room assignment to patient departure. Our target or goal is a 20% time reduction from the baseline, which is 48 minutes. Specification. We allow 20% time reduction. We allow 15 minutes from our target. That would be 63 minutes. We have run process capability report from room assignment to departure, and that gave us this defect definition. Our defect is defined as more than 63 minutes from room assignment to departure. And based on the process capability that we have run, our performance capability shows that there is more than 500,000 of defects per million opportunities. That gives us a short-term process sigma of 1.5 and a long-term process sigma of negative 0.05. So our process is not a good process. Change acceleration process tool. So we have used the Pew matrix. Pew matrix is one way of making comparison among alternative solutions. So I have come up with three possible solutions. One is to give by phone report only. Second is to automate. Remember, I discussed earlier that we print a handoff tool, a paper thing from the electronic medical record, and we write down some information like how much oxygen is the patient on, what's the activity of daily living, is the patient independent or not, is there a pressure ulcer, what's the contraptions. So we write it down. So in replacement of that, why not from the electronic medical record, those information can be pulled out, and it will be automatically incorporated or generate from the printout, or it can be available electronically also. So that's a second alternative. Or alternative three, there's a tab in our electronic medical records that we can use already. That's an existing tab that shows the chronologic order what transcribed in the emergency department. So one is to give report by phone, second is to create another feature of the electronic medical record, and the third one is to use an existing feature of the electronic medical record. So I have here three possible solutions, and I have taken the opinion and the input from both ED nurses and inpatient nurses. I made comparison based on four criteria, namely ease, impact, is it promoting SBAR format, and the efficiency. So with this, the ideal would have been alternative 2, which it follows the SBAR format, which the Joint Commission recommends. But that would be not possible in that immediate time frame, because we have needed to coordinate with information technology. We need to do a lot of things for that. So we just stuck with alternative 3, wherein there's already an existing tab, and use whatever we have and work from there. So this is again the flow chart that we have used, and this is our proposal. So we cut off that printing of report, completing it, and faxing it over upstairs, and just view report in Epic, or our our electronic medical records. So that's a big cut. And again, it says our historical mean is 61.9 minutes. Our target is 48 minutes, with our specifications from 0 to 63 minutes. So I have worked with information technology and asked us to disseminate this information for the floor nurses to see that we have an existing tab that they can use instead. There are provisions for this new process. First is that the Joint Commission requires that handoff communication to provide an opportunity for discussion between the giver and receiver of patient information. Hence, the ER nurse will still call the unit to give report and to ensure that the receiving nurse is ready prior to sending the patient up to the designated unit. Potential for patient harm, which ranges from minor to severe harm, is introduced when the patient is transported to the unit and the nurse is not ready. Thus, it is critical for the ER nurse to call and ensure that the receiving nurse is ready for the patient. If the nurse reviews the information and has no questions, he or she can call the ER and tell them to send the patient before the full 15 minutes. Documentation. It will be of great benefit to chart handoff details like time of unsuccessful or successful phone reports, name of receiving nurse, and cause of admission delays, and time of transport to the admission room. So this process has been doing well. We started this in December of that year, and for the first quarter, it shows promising result, or great reduction. So this was December of the year, or the baseline, which is 61 minutes. Of course, this slide shows chronological order by month, but we started from December of the year before. So the trend is downwards. December of the year previous is 61. January, there has been an increase, and then a decline based on the project implementation. Um, when we started this project, we have also implemented. We have we have started this survey asking what their opinions are, and we have received promising results. Of course, there has been an adjustments or resistance from other nurses. Some nurses are not used to checking it. This is a new process. There will be resistance. That's expected. But as we go, so where is this project going? So it is our hope that we can expand this process to hospital-wide scenario and improve other aspect of handoff. Like this project has focused on the time aspect or the length of waiting time. Maybe later on we can move forward and see the quality of report. Like, are we really adhering to the S-bar standard of giving report or handoff? And eventually, once everything shows there's a strong evidence of improved communication and decreased waiting time, we can incorporate this to our um, policies and procedure to have a revised handoff policy. So I hope with this information that I have just shared regarding our project in improving the admissions, um, you can find ways on how to improve your processes in your own organization. So that would be all for today's presentation. If you would like to have some input, suggestions, questions regarding how I conducted this project, please let me know. I will be willing to help you as much as I can. Thank you.